Well, hello again, everyone, and welcome to today's lecture. This is the first in our series of Normal Radiographic Anatomy. We're going to start with the hand and wrist, and then we're going to move up the upper extremity to the elbow and shoulder, and then we'll go down to the foot, ankle, then the knee, and hip and pelvis, and then hopefully I'll be able to, before the Christmas and winter vacations for everyone, and obviously before your exams in the new year, I'm hoping to be able to get done the spinal stuff as well. But ultimately, you guys have got a lot of extra reading to be doing in the meantime. So this lecture series is the reason why I'm putting it out for people is ultimately anyone who is going into a career in chiropractic and osteopathy and physiotherapy, or any types of manual therapies, or anyone looking, if you're starting off your career and moving into looking to go into more sort of diagnostic imaging later on, then it's important for you guys to be able to understand. You have to be able to get it burnt into your retinas, burnt onto your brain. You have to be able to understand what normal is, what normal for whatever area of the body you're looking at, whatever diagnostic imaging process you're looking at. So whether that's MSK stuff that we're going to go through today with plain film, whether it's going into MRI, whether it's neuro, with brain CTs and MRIs and stuff like this. You need to get down your anatomy. You have to know anatomy, and you have to be able to get your eyes and your body into as many different normal radiographic anatomical images as you possibly can, so that when you are playing the game of radiology, you're basically playing spot the difference. But you need to be able to understand and be able to differentiate what it. You have to understand what normal is, and you have to have a good database in your memory bank of what normal looks like. So in order for you to be successful in radiology, you've got to have a better understanding of what normal looks like than it is necessarily for pathologies, because ultimately the pathologies are going to be the ones you're going to see in clinical practice normally, because people are going to present to you with an issue, and therefore obviously in order for you to be able to spot the abnormalities, you have to be able to understand, obviously therefore starting with the basics of what normal looks like. And then of course things like fractures and dislocations and other pathologies become really obvious. Radiology in particular is full of, and it's fraught with signs. You've got all kinds of signs that will be present in your anatomy textbooks and your radiology textbooks. Some of these signs are there obviously to indicate that there's pathology present, and you may not be able to see it at first on the image you've got. So if you've got an occult fracture of something, for example, if you've got a fracture of the elbow, but you can't see the fracture of the elbow, because ultimately what you're looking at is you're not actually looking at the patient. This is important for you guys to get your head around. You're not actually looking at the patient, you're looking at a two-dimensional projected image of the patient. So you're not actually looking at the three-dimensional object that is the patient. You are X-rays and MRIs. These are two-dimensional compressions or impressions of your three-dimensional object being the patient. So you're, especially in radiology, in terms of plain film radiology, you are looking at lots of tissues overlying each other. Some of these are different densities, some of them same density, so it's really difficult sometimes to get your head around these things. So the signs that are there are very, very helpful in order for you to be able to differentiate, again, the normal from abnormal, especially with things around the elbow, because the X-ray itself may not be very visible or at all visible in the X-ray, but if you can see the Sale signs around the elbow, if you can see fat pad signs and things like this, or if you can see the fallen fragment sign, then it tells you what the problem is, and also indicates that there is a problem that needs further investigation, because you can't see it on this X-ray. You've got evidence that shows that there is an X-ray or there is a pathology present, you just can't see it right now. So getting your head around the signs and understanding and remembering a lot of these signs are going to be so important for your careers going forward. So get these burnt into your brain, so when you see it, you know what it is. And of course, other serious pathologies like cancer and infection, of course, these also become very obvious as well. Once you have a clear picture of your mind exactly what normal looks like, what you're supposed to see when it is normal, so that then of course abnormal, really jumps out. So let's get into it with the wrist. Okay, let's go through the X-ray series first. So standard X-ray series, of projections include a pedal, a lateral, a medial oblique, and then you've got ulnar deviation or ulnar flexion, depending on which textbooks you're reading and things like this. These are the 4 standard images you would take with basically any X-ray of somebody's wrist. You know, symptoms like falling onto an outstretched hand, especially in pediatrics and obviously children and adolescents, or when you get to adults, it's usually things like falling onto an outstretched hand whilst drunk, or just simply fell over whilst drunk. Are going to be, you know, there's going to be A&E departments that are full of patient files that just simply say fell over whilst drunk. So that's going to be your mechanism of injury, that's your history, so you know roughly what you're looking for from there. So let's get into a pedal wrist. So it is obviously it is a standard projection for best analysing the overall anatomy. You will obviously be able to see the carpals, the metacarpals, the distal radius and ulnar, and of course the syndesmosis between the distal, ulnar and radius. The central ray or the central beam is midway between the radial and ulnar styloid processes. So on the X-ray, if you were to take this image yourself, you would palpate the ulnar stylus and the radial stylus and then split the wrist down the middle, and that's where your central beam or your central ray is going to be. And then you should end up with an image that looks roughly like this. So now we get to play the game of label the anatomy, and just before anyone jumps out there and says anything or spots it for me or anything like this at all, just to let you know, the more astute clinicians out there, the more astute students out there will already have spotted this little metallic object that's sitting in the base of the proximal phalanx of the thumb. This is a surgical instrument that has been implanted in this bone following a previous trauma. So just to let you know, if you look this case up on Radiopedia, it will tell you that this is a normal wrist, but the patient has had previous surgery for an underlying or a previous injury, sorry, so this is a surgical implement. So let's label the anatomy. So we've got the distal radius, we've got the distal ulnar, we've got the ulnar styloid process. I didn't label the radial styloid process up here as well beneath the scaphoid. Then you've got the syndesmosis between the radius and ulnar, because ultimately this is a joint, this is a mobile joint. Obviously the wrist and forearm are capable of pronation and supination, so therefore this is going to be a mobile joint. It is therefore also capable of being dislocated as well, so if you can have a fracture dislocation of the radius or ulnar, and of course you'll either have a subtle widening of the syndesmosis on a pedal film, or when you get the lateral projection you will see if there's any anterior or posterior displacement of the radius or ulnar in relation to one another. So it's important for you to understand that obviously this is a joint and it is the syndesmosis. There are obviously going to be therefore capsular ligaments around here. You're also going to have the interosseous membrane running all the way up obviously where the gap between the two bones. And of course you've got the metacarpals labelled 1 through 5. So you start with the thumb as number 1, and then 5 is the little finger. That's how you label the carpals on an X-ray. Okay, so starting from you go from the left to right, and this is the same with the carpals that we're going to go through in a moment. You label them from left to right and left to right. So that's how you do it on an X-ray. So if you've got a fracture of the third metacarpal on an X-ray, it is this one. Okay, so label the carpals. Ultimately, obviously their names are listed here quite conveniently. These are, again, if I go back to the last one, so these are labelled from left to right and then left to right, so that you start with the proximal row and then end with the distal row, and you start from left to right. So you've got scaphoid, lunate, triquetrum and pisiform as your starting position. Okay, so scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate and hamate. Those are listed from left to right, proximal row, distal row. The mnemonic to help you remember this, again in order, some people choose to use, is some lovers try positions that they can't handle. Obviously going scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate and hamate. Okay, so that's an easy way for you to remember the order that you label them in on an X-ray, going from the proximal row left to right, distal row left to right. So let's label the carpal, shall we? So we've got the scaphoid, the lunate. The reason why this bone is called the lunate is because you can't appreciate it from a pedal or necessarily a lateral view properly because of the superimposition of all the other carpal bones over the top of it. So, but if you have a patient who's falling onto an outstretched hand and they have a dislocation of the lunate, it becomes really obvious because it looks like a half moon. This has got a curved, where it articulates with the capitate in the middle, the lunate has a curved top surface to it. The distal surface is curved, so it looks like a half moon. Then you've got the triquetral and the pisiform, which on the P2A X-ray are going to be superimposed on top of each other. If you hallucinate with me for a moment, you can see the articular surface of the triquetral bone, and then underneath that you've got the pisiform. The pisiform is located anteriorly in comparison to the triquetral on a P2A X-ray. Okay, so you can just about see where they superimpose on top of each other. You can see the two cortices overlying each other just there. Then you got the trapezium and trapezoid. These are always a bugger to remember which one is which. I have got no real easy way for you to remember this, apart from the fact that the first one, the I, is obviously is right after the Z, but otherwise I have not come across an easy way for you guys to remember this other than just keep drumming it into your heads exactly which goes. Trapezium, trapezoid is the order, but as I say, this is an absolute brain fart when you're trying to get it down for the first time. So just take your time when you're learning the carpals, guys. Then you've got the capitate, which is obviously the largest carpal bone, right smack bang in the middle. And then you have the hamate, which is a very unusual shaped bone, and you'll see that better on one of the projections in a little while. So those are your carpal bones, labelled again from left to right proximally and left to right distally from the proximal and distal rows. Get this into your head, guys. Remember how this is done, just because it's going to be so much easier for you going forward. Just know your anatomy, alright? This is what it looks like on an MRI. So just to show you a textbook normal wrist on MRI, you've got the distal radius and ulnar. We can't see the ulnar styloid process because that's obviously is a little bit more anterior than this projection will allow us to see. You've got the scaphoid, and then of course the lunate, triquetral, capitate and hamate. This is probably the trapezoid, but it's obviously, you're not looking at the full thing because ultimately MRI are obviously small slices through each one. So that's just so that you can see it on an MRI. And then of course you've got the articular surfaces. You can see the obviously the capsular ligaments surrounding all of the carpals, and you can also see the cartilage where they articulate with each other, just there. On a lateral projection then, let's move on. So again, you're checking really for carpal alignment on a lateral projection. As I just said, when you have a dislocation of the lunate, it becomes really obvious because it is nowhere near where it's supposed to be. The rubber ducky sign is the superimposition of the scaphoid, which makes up the head and neck of the duck, the lunate, which is the body and wings of the duck, and the triquetrum or triquetroid or triquetral. Absolute pain in the arse to say, isn't it? Just why does it have to be there? And that makes up the tail of the duck as well. So just to let you know, I'm not mental. All right, the rubber duck sign is a true anatomical thing. I will show you it in a moment. Because when you look at when you have the carpals in their correct alignment and you've taken a lateral projection in the correct anatomical position, you will have full superimposition of all of the carpal bones on top of one another, and it looks like a bloody duck. All right, so I'm not, depending on who you talk to, I'm not mental. Okay, that is a true thing. There's even worse sign in a moment I'm going to show you. Also, you're looking for the anterior fat pad, or this is the fat pad and the border of the pronator quadratus. Is well visualized on the lateral view. This is this soft tissue sign that's shown or visualized anteriorly to the distal radius and ulnar. Displacement or obliteration of the fat pad indicates a sign of pathology. Okay, so it indicates that there is a fracture of probably the distal radius or ulnar that you may not have seen first. So if if you can visualize the fat pad, and then that's great, and if it's in the right position where it should be, then great. If it's been displaced anteriorly, so you've got that displacement, or if you can't see it, if you've got obliteration. So obliteration is always a word, it's a very dramatic word, it's always used in radiology, where it's used all over the place. If you can't see something, it's called obliteration of whatever it is you're looking for, and it's a sign that there's a pathology or the sign there's a change. The central ray or the central beam is over the radial styloid process when you're taking the image. So this is it from the side. Radial styloid process is obviously just underneath the proximal part of the thumb. You have the anatomical snuff box around here as well, so it's just proximal to that is the central ray, and you'll end up with something that looks like this. So same patient again with the surgical instrument in there. So just so that we're all aware, this is the anterior fat pad that we are looking at. This is therefore the muscle belly of the pronator quadratus muscle. This anterior fat pad is the best visualized on this view. It should be seen just anterior to the distal radius and ulna. And if you have obliteration of it or it's anteriorly displaced, then of course, as I say, it is a sign of a pathology, such as in this picture just here. So this is obviously a child. This is an immature skeleton. We've got a large growth plate separating the around the epiphysis. Here's the fat pad sign. So it should be just off the border of the. If I go back to the normal. So just here, it is really quite close to the distal end of the radius, and on this one you've got that anterior displacement and obliteration of the rest of it. You can only see a tiny portion of it, the rest of it is obliterated, you can't see it at all, so this is indicating that there is a fracture, most likely somewhere around the distal radius and ulnar region that we can't quite see on this image. So check the rest of the series and you should be able to see where the fracture is. There we go, so that's the anterior fat pad displaced. Here's the rubber duck that everyone is probably very much looking forward to understanding. So if I jump back to the normal just here, so here's the duck's beak, here's the duck's head, there's the body, there's the tail, there's the body and wings. So this is obviously the scaphoid, this is the lunate, and then this is the triquetral back here. If we jump forward a few again, just so here we go, I've drawn it all out for you. So duck's head, body, and the tail. You can start to see just here, this is the obviously distal articular surface of the lunate. You can start to see why it's called the lunate, because it has that half moon appearance to it. So this is the scaphoid, lunate, and then triquetral again. The reason why this sign is so important for you guys to be able to see is not only does it tell you that you've taken the x-ray correctly, you've got a true 90-degree movement of the patient's pedal wrist to take the lateral, so you've got the correct positioning of the patient, but you've also got this, the pooping duck sign. I told you I was going to show you a worse sign than just simply the rubber duck sign or the rubber ducky. So the pooping duck sign is where we have an avulsion fracture of the triquetral back here. So you've got the scaphoid, you've got the lunate, and where the triquetral makes up the tail of the rubber duck. If you have an avulsion fracture of the triquetral bone, then basically it's labelled as the pooping duck sign, because the avulsed bit of bone is supposedly looks like a piece of poo coming from the duck. All right. This is obviously shows you that what happens to you when you become a radiologist and you spend your whole life sitting in a dark room by yourself, effectively talking to yourself, you start to make stuff up, don't you? So this is, and obviously clearly not all medical professionals are as as mature as each other, or some of them actually do have a sense of humour, and they probably found in radiology departments. Those are the conclusions I've come to as to why this is called the pooping duck sign. But there you go, it shows that there's an avulsion, and obviously just here as well you can also see there's quite a lot of soft tissue swelling on the posterior aspect of this patient's wrist. Again, it just shows you where the injury is. You've got quite a lot of soft tissue swelling just there as well. But notice the fat pad, the anterior fat pad, is present and correct. So this will not show when you have posterior element fracture just there. Moving swiftly along, let's go to the medial oblique. So the great thing about the medial oblique view is it removes the superimposition of the carpal bones and the rubber duck appearance. Okay, so if you're looking to be able to see the carpal bones as more of the individual location or individual integrity, then taking a medial oblique view is the way to do that. Basically, you get the patient. If you're going from the PA view, you move the patient 45 degrees in external rotation of the wrist to achieve the view. You can also achieve it by using a triangular wedge piece of foam to help to support the hand and wrist, because ultimately the patient's most likely got pain in this area. So if you're able to, if your equipment allows you to do that, use a triangular piece of foam to just support the wrist at a 45-degree angle, and you'll get the image that you're after. Like I say, it's great for evaluating the carpals as individual bones as opposed to superimposed on top of each other. Central ray is, as usual, midway between the styloid processes. This is roughly what you would achieve. I don't think I got my wrist quite at 45 degrees, but that's roughly what you're after. And this is what it will look like. So you can see where obviously the head and neck of the rubber duck comes from, because you can still kind of see that. But because you've removed the superimposition of the bones, it is slightly better for you to visualize the carpals as individual structures as opposed to superimposition, super overlying on top of each other. Not great for alignment. You can't check the alignment of the bones. So if you haven't taken a true lateral and it looks a bit more like this, then again you haven't got the right anatomical positioning of the patient. So you are going to miss any sort of subtle subluxations or dislocations of the wrists, of the carpals. But again, it's a true examination of it. This is what it should look like. Ulnar deviation or ulnar flexion. This is used to stress the scaphoid, looking for it aids in the detection of fractures. There is a specific scaphoid series that I'm going to show you in a little while, where you basically do all of these views, but you're focusing on the anatomical snuff box and the position of the scaphoid. But if you're just doing a wrist series and you're not specifically investigating the scaphoid, then you can still do this view, and it aids in the detection of subtle underlying fractures of the scaphoid. And obviously it allows for evaluation of motion and structural or segmental stability and integrity of the carpals as well. So if you end up doing an ulnar deviation and you find that there is displacement between the articular surfaces of the scaphoid and the lunates, for example, then that shows you that there is going to be some damage to the ligaments, and it will cause a separation of the two bones. This is again roughly what it should look like in terms of if you're going to take it, and then this is the image you will end up with. So the great thing about this view is it really brings out the scaphoid. Okay, so you can really see it's in a much, because the central ray is right over the top of it, you'll get a better position, you'll get obviously better view of it anyway. But because it moves it away from the distal aspect of the radius, it really allows you to assess it in much more detail. And if you've got a fracture of the waist of the scaphoid, as you do this view, you may find that the fracture line becomes enlarged or widened, and so you end up with a decent image of that. Or, as I say, if you've got disruption of the ligaments between the scaphoid and the lunate, for example, then you will get a separation of these two bones as you do the image, so the gap widens, and that shows you that there is a fracture. That sign is also called the Terry-Thomas sign, where you've got a widening or a gap between the two. Additional projections. So if the standard projections don't show you anything, and yet the patient still complains that there's obviously pain and discomfort, there are additional views you can take as well. The carpal tunnel view, angulated scaphoid, which is just part and parcel of the scaphoid series, and then the ball catchers projection is always a helpful one as well, specifically for if you want to look at the pisiform. So carpal tunnel, This is obviously used to evaluate the carpal tunnel in terms of its size and obviously the volume of space. It can be used to assess for space occupying lesions within the carpal tunnel, and obviously you will also get a really good image of the hook of the hamate. So if you've got a fracture of the hook of the hamate, it is better seen on this projection. The only problem with this view is it depends on what your equipment will allow you to do. So for example, I am a chiropractor, so my x-ray machine is mainly set up for standing spinal images. I can do other images as long as the patient is capable of standing, and I do elbows, shoulders and wrists and knees and things like this when a patient presents with these particular ailments and issues. But I can't, or will very much struggle to get a decent carpal tunnel view because of the way you take the image. It can be really difficult to be able to get this view because the patient has to be able to really flex the wrist as far back as you can, and of course then trying to get a view, trying to center the ray through the carpal tunnels are really difficult to do with my particular piece of equipment, and that'll be the same for a lot of clinics and a lot of setups where you've only got a standing upright bucky. So this is not a standard view in my office, but obviously in A&E departments it is a standard view because their equipment will allow them much greater variability in where they can put the patient. And this is what it looks like. As you can tell, the patient has to be able to flex their wrist backwards as far as possible in order for you to be able to properly visualize this. So, labeling the carpals, number one is obviously the trapezium, then you've got the scaphoid, capitate. This is the hook of the hamate, just here, number 4, just here you can see why it's called the hook of the hamate. You miss this on most other series and projections of the wrist, so this is a great one for that. And then this is the pisiform, and this is the triquetral or triquetrum, depending on what text you're reading. This is obviously the carpal tunnel, so you'll have the surrounding retinaculum around here, bridging the gap, and then in here you'll obviously have the median nerve, and of course the arteries, and of course you'll have the tendons of all of the fingers as well. So very, very busy area, this area. Just to let you know, again, on Radiopedia, fantastic resource for anyone obviously learning radiology or obviously looking to brush up on their skills. This is a very, very helpful diagram that allows you to try and remove some of the superimposition of the carpal bones. Ultimately, you can see, and you do have all of the carpal bones present in the x-ray, but if we jump back to this view, it's really difficult to be able to distinguish them properly because ultimately these tissues are all of the same density. On an x-ray, or especially on an x-ray, let's just stick with x-ray sprigs, because when it comes to x-ray, what you're looking at is a grayscale. All right, so you're looking at in head CT, it's called, they're measured in Hounsfield units. So you use that to be able to differentiate soft tissue from bone and metal and stuff like this, and obviously acute blood and things like this in head CT. But that's CT. This is specifically plain film X-ray. So it's really difficult for you to obviously be able to really differentiate all of the carpal bones present in this view, because obviously everything is the same density. All the carpals, metacarpals, they're all the same density. So as you mix them and match them over the top of each other, you won't be able to tell the difference reliably. You can tell the main ones, but down here, really difficult to see exactly what's going on. So this diagram is really, really helpful when you have if you have an image that's got slightly better contrast, or if you're able to play around with the contrast nicely with the digital x-rays, then you may be able to get a different view or a better projection of all of the carpals, so you can see them all properly. But this is a very, very helpful diagram for you to get off of Radiopedia to help with your revision when you're doing this work. Specific scaphoid series. So depending on what textbook you read, the ulnar deviation scaphoid is also what's called the elongated scaphoid view, where again it just makes the scaphoid slightly longer in its appearance. It's really good for you to visualize fractures and things like this. Like I said at the start, the scaphoid series is the same series as the wrist, with a PA oblique lateral and then ulnar deviation, but ultimately what you're aiming for is to have the scaphoid as close to the central beam as you're going to be able to get it, so that you crop it down, you collimate in really specifically on the carpals to really try and remove all the other overlying anatomy, because the scaphoid is a very commonly fractured carpal, so it has its own series of evaluation available. The ball catchers, this is mainly used to evaluate the pisiform. It can be used to assess the whole hand, so it's not just a wrist view. This does fall into the hand category as well of a hand series. Good visualization of the phalanges, the metacarpals, carpals, distal radius and ulnar, but ultimately the pisiform is a really good evaluation tool with this. That's how you take it. The patient has the appearance that they're looking to catch a ball, which is obviously clues in the name, and this is what it will look like. So ultimately, again, as I say, you can see distal radius and ulnar. You can see the carpals with the real good way of looking at the pisiform in particular, because it really stands out. Then you got the metacarpals, and then of course all the phalanges. And of course the great thing about this view as well is because you are looking at both hands simultaneously, if there is an abnormality, if you've got a patient with, for example, who has got rheumatoid arthritis, this is a great way for you to better evaluate both hands in their entirety without having to do loads and loads of views all at the same time. And it just gives you a slightly better way of visualizing the shafts of all of the long bones of the hand. So moving into the hand then, it is noteworthy that the whole hand, from the distal phalanges to the distal radius and ulnar, must be visible on a hand series. Okay, so ultimately that does include therefore the carpals, it includes the wrist. The wrist has its own specific set of views and methods of evaluation, because ultimately if you've got a patient who falls onto an outstretched hand, if they've got that mechanism of injury, the injury is most likely going to be to the wrist, whereas if you've got underlying inflammatory conditions, or if you've got a patient with degenerative disorders or an underlying pathology like they've got systemic lupus or scleroderma or rheumatoid arthritis, then this is why you'd really take hand series. And of course, if you end up with, as I went through with my students recently, if you have trauma to the hand, so if you've got a traumatic amputation of a finger, for example, then you would also therefore take hand series and images of the fingers, because ultimately that's what you're assessing for. Standard views are P2A, lateral and oblique, same really as the wrist. P2A hand then obviously uses standard to assess the overall anatomy, can and should give visualization of the soft tissues as well. So if you've got a patient who has obviously, for example, they have punched something really hard, or they've punched one of their mates, you will get soft tissue swelling and edema around the area, which is a good visual. It's a good visual tool, even if you can't necessarily see the fracture on the first set of images. Central ray is the metacarpal phalangeal joint of the middle finger. Okay, so it's the knuckle of the middle finger. So that's what you're aiming for in terms of the central ray. Okay, I've taken these images as well, these photos, to show you what it looks like from both angles. All right, so this is obviously just to show you. And this is what it should look like. So again, we've got from the distal phalanges all the way down to the distal radius and ulnar. Gives you a different view of the carpals as well. You can see the sort of the half moon shape of the lunate as well, with the posterior and anterior areas of it. And again, this is because it's not the central ray. The central ray is here, so this is, you're looking at it from the top down because of the divergence of an X-ray beam, and this is all down to your X-ray physics. So you must again understand the physics of how an X-ray is produced, so that you can actually tell the difference, and you can also therefore understand why you would take certain images over others as well. Soft tissues as well, you can really see the outline. You can even see the shadow of the nail bed as well. It's quite impressive what you can see these days on digital X-ray. So if you do have an underlying fracture and you've got bulging of the soft tissues, or you can't quite see the fracture, again, it's a nice handy sign to show you that there's probably a fracture present, you just can't see it. So just to go through it, obviously you've got the carpals, then you've got the metacarpals, and then you've got the phalanges at the end. The way you label them as well is it will move again from proximal to distal. The base of the metacarpals, then you've got the shaft, then you've got the heads, and that is the same for the phalanges. The proximal end is the base, then you've got the shaft, and then you've got the head. This is always helpful when you're labeling, for example, especially avulsion fractures of the distal or proximal distal interphalangeal joints, because you can tell where it is by simply saying that if it's of the base of the proximal the proximal end of a phalanx, then you know that it's at the base, whereas if it's at the distal end, it's of the head of the phalanx as well. So that's how you label them as well on the x-rays. So the lateral hand is obtained, you can either have it with or without spreading of the fingers. Most of the time it will be taken with spreading of the fingers, and I'll show you why that is in a moment, because ultimately the fingers will be superimposed on top of one another. But again, it depends on what you're after, what you're looking to achieve with the images. You can take them with the fingers together and then take them spread apart. Typically again with the fingers spread, so you can get better visualization of the phalanges by doing that, because obviously when they're all together they're going to be superimposed on top of each other. Central ray is the medial aspect of the second metacarpal head, so it's right there on the index finger, just there right at the so the metacarpal phalangeal joint just here. This is with the fingers together, this is with the fingers fanned apart. You can see what I mean. If you take them so that they're together, you are going to find that all of the phalanges are superimposed on top of each other, so it makes it very difficult to see them. However, when the patient does this, some patients, obviously, you're taking these images because things are painful, things are swollen, so it might not be all that easy to achieve. And this is what it will look like on the x-ray with the fingers spread. Okay, so this particular patient is basically just making them do the OK sign, and this is what you'll see. It's got great visualization of the thumb, and of course all the phalanges just here. So if you've got an avulsion fracture somewhere around here, you'll really see it. Obviously the tendons run anterior or posteriorly, so that's where the most likely position of an avulsion fracture is going to be, and that is going to be a forceful flexion or extension of the finger as a result of catching a ball, for example. So yeah, that's what it will look like. You can obviously just about make out the rubber duck sign down here as well. So again, quite helpful, and you've also got the anterior fat pad present. So great for visualizing all of the anatomy. So the oblique CAD is used obviously when you're assessing for pathologies that might be missed, especially of the metacarpals. That you'll probably miss on the AP or lateral projection, so the oblique is always a standard view as well. Like I say, great for metacarpal fractures that might have anterior displacement. If you've got anterior displacement of the distal fragment of a metacarpal fracture, you will miss it on the AP view, and on the lateral view, unless it's displaced in a great deal, or if it's ultimately, you can see the superimposition of all of the carpals just metacarpals just here. So if it's within the first two, for example, if there's not much displacement and it's in the mid shaft, you're not going to see it. It's really difficult to see because of the superimposition of all the other tissues over the top of it. So a oblique position is always very helpful. It is obtained again with a 45 degrees of external rotation of the hand and wrist, and the central ray is the third metacarpal head, so that is again the knuckle of the middle finger. And this is what it will look like. So again, as I say, because of the way the projection's taken, if you've fractured the shaft of the third metacarpal, for example, and you've got an anterior displacement or an anterior angulation of the distal aspects of the distal fragment, AP view, you won't see it because these two tissues are still lying over the top of each other, so you might miss the fracture line, and this fragment has gone forward. So on an AP view, you're not going to see that because of its two-dimensional image. On the lateral, if you've got minimal displacement of the distal fragment and the second and third metacarpals are overlying each other, then again, you'll miss it. So The oblique view is really, really helpful for really visualizing those types of fractures, just there as well. So additional views, I'm not going to go through them all because they're pretty obvious. So you can do obviously individual fingers with PDA, lateral or obliques. So basically, if you're looking to investigate the index finger in greater detail, take a PDA, take a lateral and then an oblique of the individual fingers in exactly the same way as you'll take the overall hand. You can also do finger stress views to assess stability and ligamentous integrity. This is where basically if you are suspecting a fracture dislocation or a traumatic dislocation of the index finger, for example, but the joint itself is actually back in its normal position when you first do it, or when you first observe the patient, but you're suspecting ligamentous disruption, you can take the AP view, for example, of the index finger and get the patient to forcefully push the joint over as far as they can, medially, for example. And if you look this up on Radiopedia, you will see a nice set of x-rays where you can really see how you can assess joint stability and ligamentous laxity following a traumatic dislocation. Pediatric x-rays, these are always, ped stuff is always really difficult when it comes to radiology because you've got growth plates and secondary growth centers and things like this, so it becomes incredibly difficult. This is a huge area of radiology, so I'm not going to go through the whole thing in too much detail right now, but what I will go through is obviously the carpals and their formation. Okay, so the carpal bones form from their own individual ossification centers. The capitate is first to form and is the largest bone, and it should appear approximately in the first 12 months of birth or first 12 months of life, with a new carpal developing every 12 to 18 months. The order of development starts with the capitate, then the hamate, triquetral, lunate, scaphoid, trapezium, trapezoid, and finally the pisiform. Full set of carpals should be visible on an x-ray by the age of 10, but they may not be fully formed yet. Okay, so the rule of thumb to follow, excuse the pun, but the rule of thumb to follow is you get a new carpal every 12 months or every year of life. So if we look at this x-ray, this is the overlying finger of most likely a comforter or carer or parent of that particular patient. You can see where we've got the metacarpals, we've got full set phalanges, big distances between them because ultimately this is going to be made up of cartilage. You've got the secondary ossification centers of the distal aspect of the metacarpals is forming, so the head of the metacarpals is forming out of these ossification centers. And down here we've got two carpals that are starting to form. So this child is going to be somewhere around 18 months to 2 years old. Nice and easy way to remember it. With that, 1 a year is approximately what you're going to find. And then if we look at this patient just here, so this is an immature skeleton. You've still got the remnant growth, you've still got the growth plates, you've still got the epiphyses separate. The secondary ossification centers of the metacarpals are obviously still separate, but they are obviously starting to fuse together. The thumb is nearly finished. Base of the other four metacarpals are obviously forming really nicely. You've got obviously, so the capitate was obviously the first one to form and is pretty much fully formed, but the rest of them, the trapezium and trapezoid, are not quite formed properly, and we have no pisiform that I can see on this particular image. So this is probably the ossification center just there of the pisiform. So we've got a child that's somewhere around 10 to 12 years old at the oldest. Carpal bones are starting to take shape, the scaphoid is starting to take its shape that it should do, but this is just to give you an image of what happens. And again, as I've said to my students beforehand, when it comes to these types of images, it's really difficult to know whether that's a fracture through here when you first start looking at these images, but ultimately you can see them absolutely everywhere, so it's unlikely to be a fracture. But then of course you've got slipped epiphysis where this has been fractured and slipped out of the way in a Salter-Harris type manner. So this is the peds is incredibly difficult to get into, so take your time whilst learning peds stuff. There's a great book on fractures and peds that I'll try and link in another video somewhere as well. Just going to go through a couple of normal variants. I'm not going to go through them all because things like accessory ossicles, for example, are so these are small fragments of bone or little sesamoid bones that form naturally around the wrist and fingers, and you'll also get them around the ankle and around the feet. I didn't talk about sesamoid bones that are again normally found within the normal wrist, but again, if you look back through the videos and you look into your radiology textbooks, you'll see them in the anterior aspect of, for example, the thumb is a really important one where you get at least one. You've got at least one sesamoid bone that forms within the tendon and the tendinous sheath of the thumb, but you will get them all over the place, and as accessory ossicles, most of them are benign, there's nothing to worry about. Some of them can cause problems, especially in the ankles and feet. There is os trigonum syndrome and things like this, where a secondary ossicle is starting to get in the way, and it causes problems for the patient. Some of them need surgical removal in order to obviously get rid of that problem, the offending issue. I'm not going to go through them all because there are loads of them, but these are important for you to understand whether or not it's normal, because sometimes there's an os triangular where it sits distal to the ulnar styloid process, and it can simulate an avulsion fracture of the distal aspect of the ulnar styloid process. So you need to be aware of these things. Like I said, I'm not going to go through them all now because there's loads of them. We'll be here for another hour or so just doing them. And then you've got two other underlying conditions. One's called polydactyly and the other one is arachnodactyly. Obviously this is from Greek and Latin stuff. Dactyly are fingers and poly is many, and obviously arachno is obviously spiders. I'll just tell you what they are now. So accessory ossicles, helpful mnemonics are things like lotio or hotels, where you've got the lunula, os styloidium, os triangulari, which is the one I just said. There's obviously os trapezium, epilunate, and then hamili, which they tell you roughly where they are because ultimately they're right next to where they are. So this is going to be somewhere around the radial stylus, this is the ulnar stylus, and then these are obviously around the trapezium lunate bones. So very, very helpful. The H on this one in hotels is from the hamuli. In lotio they use the os, which is really irritating because so many of them are labelled as os something, because obviously it's ossicle, which so I don't particularly like the fact that they do that in these mnemonics. It's kind of helpful, but in terms of actually helping you understand it, the O and in lotio there's two bloody O's, and both of them begin with os. So quite frankly, I don't find that particularly helpful. Just basically get your heads down, guys. Get these locations burnt into your brain as to where they are. Just so that if you see it on an x-ray you can label it correctly and understand that it is a normal variant, it is not a fracture of the area, it is not a secondary ossicle or anything like this at all, or a malunion or a non-union of a fracture fragment. It is an accessory ossicle, and it's perfectly normal. Okay, but these are a pain in the arse to get down, guys. I'm not going to lie. You just got to keep working at them. Polydactyly. So this is obviously when we've got a condition where we've got more than the normal number of digits forming the hand or foot as well. Just a little taster for when we do when we do foot and ankle. Polydactyly is still called polydactyly whether it's in the hand or foot. Okay, so just to let you know, it's still called polydactyly where we've got too many fingers or too many toes. There is an increased association of polydactyly with genetic disorders, so Pallister Horse syndrome, things like this. These are very rare genetic disorders, but you can find them in the population. So just to let you know. And here is a very, very Very, very well done picture. X-ray of a P2A hand of a child. This is obviously an infant, somewhere around the age of approximately 3, I would argue. And here we can have so obviously here we can see off the first metacarpal we've got 2 fingers developing. This is obviously what the thumb should be. Again, I haven't gone through this with you because I assume you already know. The difference between the thumb and the rest of the fingers on an X-ray is the fact that the thumb only has 2 phalanxes, whereas the fingers all have 3. You have a proximal, a middle, and a distal phalanx, and obviously each one, so they form. So the proximal and middle forms the proximal interphalangeal joint, or a PIP, and then up here you've got between the 3rd and 2nd, you've got the distal interphalangeal joint, which is the dip. Okay, so on this particular image we can see how this is what the child's thumb should have been. We've got 2, and then over here we've got 3 phalanxes developing. So this is an additional finger just here developing off of the first metacarpal. So these can happen anywhere. There is an amazing picture in the textbook where the patient's got like 8 or 9 digits and no thumb. It's incredible to see how these variants come about. This is perfectly normal. Well, I say perfectly normal. It is classed as a normal variant, but obviously how much function the child has as they grow up and as they learn to move around is going to be difficult to tell. So this is something where, whilst it is normal, this is not a pathological process. It is classed as a normal variant and is associated with other genetic conditions, but ultimately this in and of itself is not a disease. An arachnodactyly, I don't have an image to show you because it is just simply the definition of spider-like fingers, where basically you have a normal appearance of all the bones. They are just exceptionally long, so the long bones of the fingers and wrist are the ones that are affected, so the metacarpals and phalanges are the ones that are affected. It's associated with conditions like Marfan syndrome and EDS, or Ehlers-Danlos syndrome. These are obviously connective tissues disorders. These patients tend to have especially Marfans, they tend to have very long extremities in comparison to their actual overall height. We should all be aware that your arm span from tip of your middle finger to tip of your middle finger spread out, with your shoulders spread out at 90-degree angles from each other, that distance from middle finger to tip of middle finger should equal your overall height as well, as per the, we should all be well aware of Da Vinci's, is it Vitruvian Man? So we should all be aware of that picture. And in Marfan syndrome and Ehlers-Danlos syndrome, you can have exceptionally or extra long bones of the body. So the arms, the humerus, the radius, the ulna, and of course the long bones of the hand are extenuate. They are elongated, so they do have a difference in that ratio. And like I say, I don't have an image for you guys because they look normal, they're just really long. So it's just something that you need to be aware of when it comes to your learning. Thanks very much for your attention. I always say to students that learning isn't free. You have to pay attention. So it's important for you guys to have access to this material. So rewatch it at your heart's content. Feel free to like and subscribe to the channel, just so that you know when further material goes up in helping you out with your studies. I wish you all the best for your studies at the moment, and I'll see you all in the next one. Take care of yourselves.